is, well, isn't race just a proxy for socioeconomic status?
You have, I see a picture. Okay.
If somebody could mute, I think I'm hearing somebody in the background. I think there's a couple of folks here who aren't on mute, just so you know. This one I've kind of tried to turn around in my head. So when I have this thought, I actually try to turn it into, well, what if socioeconomic status is just a proxy for race? Just to kind of turn that reaction tendency on its head. And then this one, because I'm very invested in the cognitive neuroscience world and scientific theories of brain function, I still find it problematic, though, that we often retreat to this defensive position that this is not a particularly helpful statement, but sometimes we act like it's an argument. We say, well, don't you think all behavior comes from the brain? Isn't the brain important? Well, that's true. But what we're talking about in no way minimizes the importance of the brain. It just tries to take away this idea that there's a biological, deterministic, or biogenetic, to use the term, sort of source of behavioral disturbance that is the most important. And so I'll tell you like a story just to get us thinking about the types of issues that I want us to re-explore. And I'm going to go back to when I was a medical student. And I think a lot of what I've learned is that the way that I picked up diagnosis, I think it's hard for me to think this because I don't like to think of myself as a biased person, but the way I picked up diagnosis and crafting sort of discussions with patients and maybe how I would frame the term insight was really kind of given to me in a way that I think at the time I didn't realize just how deterministic it was. But one of the things that really I had this sort of, I guess I'd call it jarring experience when I was a medical student. I was working at the VA hospital in Central Illinois, and I was interviewing a man who was in the hospital. So I was just doing my standard medical student intake interview that I was going to present to my attending later. And I don't remember details about the diagnosis per se, other than I think depression and suicidality were part of the presentation. But I remember at the end, after I went through this long interview, this man looked at me and he asked me, and he said, tell me, doc, do you think I'm crazy? And so that question, I'd never been asked it so directly before. And so I can't remember exactly what I said, but I know the gist of it. What I said was some version of what I had been taught from textbooks and role modeling. And that was that you're not crazy, right? You shouldn't blame yourself. You just have a problem in your neurotransmission in the serotonin system. And your brain has a chemical imbalance, and that problem in serotonin causes you to be depressed. So I think that was probably the narrative. This is the early 2000s, where I think that was probably one of the more powerful narratives for depression. And I remember very clearly, so I dutifully gave him that explanation, which I thought was a stigma decreasing explanation in my mind. And he looked at me and he said, I think that's just another way of you calling me crazy. Right. And that really stuck with me, because I remember even at the time, even in my sort of, naive state, I actually paused and I go, I think he's kind of right. Right. I think he's kind of right. Like, I haven't actually given him much useful empathic narrative. I've just reframed crazy as a problem in your brain. And so that's always stuck with me. And I think we often make that sort of simplistic error thinking that we're reducing stigma. My question would be, are we actually reducing stigma when we do this? And then a further question I want us to struggle with is, when and how are we more likely to use a biogenetic explanation? For which patients are we likely to say the problem is in your brain? And for which patients are we likely to say you're just experiencing normal suffering, right? What are the biases packed into how we make that decision? And just because I want some of these biological explanations that certainly I have been taught, and I think are still kind of implicit in the way we talk about medical disturbance, and this cuts across medicine. This is not just in psychiatry, but I'm going to use a psychiatric example. So I want us to think, this is just an imagination exercise. So I just want you to all just sort of pause, and we're going to do a little group experiment. So just focus your eyes on the screen. And I'm going to start a theoretical brain scan now of all of us. I'm going to be scanning all our brains as I shift the screen to this. So let's say that I have a high fidelity EEG or MRI, and I'm able to capture the average of brain activity. What do you all think? Feel free to put in the chat or just shout out. What do you all think I might find on a brain scan? The difference between this and this. I would probably find a signal. What do you think that signal might be? Amygdala, almost certainly. Right? We might get some extra activity in the visual cortex because we're going to be scanning a new image that has much more salient detail than the image I showed you before, which was a very simple image in terms of its salience or threat potential. I also purposely chose this picture of the dog because if you know dogs, this dog, there's signs that it might be angry and there's actually signs that it might not be angry. So it's a little ambiguous, right? This dog may be about to attack you, but may actually just be yawning. And so there's some ambiguity, and so, but it would probably trigger your threat detection system. This is something, and the amygdala would probably, quote unquote, light up, right? So let's say I found that. Let's say I found in everybody's fMRI, for whatever reason, right? When I show this, there's an average increase. Now there's a range, but I just want us to think, because I think I'm being a little bit facetious here. I'm making a point, but I actually worry that sometimes the way that our field interprets neuroimaging data is going to be in the way that I'm going to tell you right now. And so I just scanned your amygdala. I have all this data. Can I say that amygdala activation causes a dog phobic fear response? It certainly correlates. It's pretty reliable that when I show a dog, the amygdala activates, and then you say that you feel a little bit fearful. So maybe the amygdala activation causes that fear. Remember, the background question here is, did that cause the fear or did the dog cause the fear? Could I say that glutamate excitation in the amygdala is a biological underpinning of dog phobia? Sort of. That's sort of true. But I would say, is that useful? Is that a useful statement? It is probably a true statement. And then let's say I find that 50% of you have this, by definition, one standard deviation larger than average response. Can I then say, you have a mental illness, you have an abnormally activating amygdala, and your dog phobia is due to a dysfunction in the biology of your amygdala? Right? Do you think those are fair statements that I made? So just think about that, because we often, if we're working with what we've decided is a mentally ill population, remember, we don't think of ourselves as a mentally ill population, the faculty and staff here, but if we were scanning a mentally ill population, we would be much more likely to make these types of causal inferences based upon exactly the same type of ambiguous data. So I want us to really question how and why we do that, and at the societal level, who gives us power to do that, and what is the implication of us being able to do that? So maybe some of you were at my talk last year, so I've been trying to tie together the Bay Area series to have some themes, and social justice is one of the themes that I want us to have. And so last time I talked a little bit about how I felt DSM was actually perpetuating injustice, right? And I'll remind you why I said that, because it's going to be pertinent to our discussion of stigma and biological race today. And what I just want to remind us of this. So my talk was a little bit more of a deep dive into how we frame diagnosis and the philosophical underpinnings. But I want us to point out, if I was going to pick out what is the primary error in DSM, and I'm going to say not just primary error, but what gives DSM the potential to cause the most harm. It's not this. I actually think this is actually probably where DSM should have stopped. It should just say, well, we've defined these syndromes. We've defined them by disturbances as defined by sort of societal norms in cognition, emotion, regulation, and behavior, right? And epidemiologically, syndromes are useful, right? So we know that if you have one problem, you're more likely to have some problems than others. We know that certain problems are likely to be chronic, certain problems are likely to be episodic. We can get a lot of information from syndromes. But DSM has this curious addition to this, which I want us to all think about how this plays out in terms of who's mentally ill and not, who gets called mentally ill, and when do we decide you have a problem in your brain. And DSM adds this, which is, I think, a completely unjustified statement. So DSM says, well, it's not just that these are syndromes that reflect a clear dysfunction in psychological, biological, or developmental processes. That is a pretty strong statement for a field that has very little, I would say, well-supported theory of brain function. This is a very strong statement. And think about the authority that I'm giving clinicians here who get to apply the DSM. I'm giving them the authority to decide when your disturbance in emotion or cognition is understandable or a quote unquote normal reaction to stress, and or separately, I get to decide when actually your behavior, get the same behavior, when the same behavior is actually reflective of some underlying dysfunction, in particular in the biology. I think we fall back on the biology as our underlying distinction. And so the assumption here that I think is problematic is that somehow clinicians, I'm going to say psychiatrists in particular, but of course any clinician who uses the DSM, why do we know what optimal human function is? And by proxy, why do we get to decide what an optimal brain is? And decide when a deviation from optimal function is a sign of a suboptimal brain, right? That's a pretty powerful statement to make. And what we're doing here is we're attributing the problem to something that exists entirely within a person, but we're attributing it based upon the same data that we have that might make us attribute it to an external factor, right? There's no extra data that allows me to say this. So this is where I think the power of DSM becomes problematic at the societal level, and it's going to act to reinforce a lot of the biases that exist in ourselves and in the larger society. And so I think this is actually put quite well. This author, Kamens, puts this quite well. I actually think that the more brain-centric explanations we use when we have, in the lack of a lot of good biogenetic data to back them up, I think we're actually colluding with the forces of inequality and subjugation. I think we're acting to reinforce inequity and racism. I don't think we want to be doing that. I don't think we're choosing to do that, but I think that's what's happening. This is my argument. And then I think the irony is that a lot of our identities, certainly part of my identity, is that I actually think of myself as actually somebody who's striving to try to provide better care for people who are suffering from social injustice. So while I'm trying to do that, I worry that I'm part of a system that is actually reinforcing it. These are the questions I want us to struggle with when we sort of see a grand rounds from a different lens than maybe we're used to looking at a grand rounds talk. So I ended my talk last year by really saying quite clearly, I think this is still true. This is why I'm bringing it up. I don't think we should accept the unjustified level of authority that DSM gives us. I don't think it's justified. I think it gives us too much power to reenact not just our individual biases, but the biases of the system that we're in. And I also, from a scientific standpoint, it bothers me that I've made this point before many times. Because I'm a specialist in schizophrenia, I get to tell you when you really have schizophrenia, but I don't have to back it up with any evidence. I just have to back it up with my opinion, right? That's all I have to do. I don't have to say, this is why you were wrong and this is why I'm right. I just say, oh, I have the same data you do, and I'm pretty sure this is really schizophrenia. I think that's an unjustified level. I'm actually not happy I've been given that level of authority. And then for the trainees in the audience, I want to remind you, I do hear you, because I hear some version of this almost any time I give a talk that touches even peripherally on these issues. And I think the trainees see this because they're new to this. I think the faculty, like myself, are a little bit more used to it, so we kind of have to extra reflect on it. It still bothers us, but I think the trainees, it's just more jarring that they see us as medicalizing what you would say from an effect size standpoint, if you wanted to be statistical, is much more affected by society and criminalization than it is by any kind of a broken brain sort of analogy that we would make. And I want to get us away from the reaction that isn't all behavior based in the brain. Yes, but does that mean that the best explanation for behavior is a brain-centric explanation? No, right? You need to separate those two things in your mind. So here's where we are today. I'm gonna introduce us again to the specific aims of this lecture series. My goal is to start a conversation that hopefully will be a thread through this Grand Round series, even if it's a thread that's only in the back of your minds as you watch the talks. I'm going to just talk about, I've been hinting at this, but I'm going to talk about specifically what we call the attribution bias. It's a very human bias that cuts across human interaction. And I want to talk about how when we combine it with some assumptions of DSM and the power given to us, I think we actually reinforce stigma instead of reducing stigma. And then I want us to touch on this. This is the issue that I really think our field needs to be struggling with. And because it's a new issue, I'm not going to be giving you the whole story, but I just want us to think about, there's a long history in this country of assuming that race is a proxy for ancestry and biogenetics. That is actually, when you start to look at it, extremely ingrained and very problematic in the sense that I would say it leads well-meaning clinicians to actually reinforce a societal structure that causes inequity. And again, check your reaction here. What I'm not saying is that evolution hasn't led to genetic differences between populations. That's what I'm not saying. What I'm saying is the way that we use race as a one-to-one proxy for biogenetics is highly problematic when you combine it with the biases in the system. And then those of you who know me know I like to also challenge myself and challenge other people. So I gave you some learning objectives. I do want those to be what you come away with at the end of the talk. But I also want us to struggle a little bit more with these emotional contexts these are more my opinion, but I want my challenge is for us to struggle with this opinion. I've hinted at this. I think biogenetic explanations in psychiatry are premature. That doesn't mean I'm not interested in them or don't want to study them or think they're ridiculous or meaningless. They're just premature. And so they actually may serve to reinforce the attribution bias that I'm going to talk about, as opposed to giving us new information about behavior. In a country with a very particular racist history like ours, this use of otherness that we apply through the attribution bias as a proxy for mental illness will inevitably lead to more harm done to Black and brown patients. That's going to be one of my arguments. So whenever we use otherness as a proxy for mental illness, we're going to inevitably do more harm to Black and brown patients, whether we want to or not. And just a reminder, diagnosis is a privilege granted to us, the people who use the DSM. And when applied as the DM intends, actually serves to reinforce structural biases in the system, even via well-intentioned clinicians. These are more my arguments. I'm happy to have these be part of a conversation, but I think they're arguments that are supported by data, and they should be part of a conversation moving forward. So let's talk about the Bay Area lecture series. So I've been running this for a while, but I've really felt more strongly over the last several years that we should be tightening up the specific aims and giving us some themes. So this is the general mission of the Bay Area lecture series. This is still true. We still try to do this. We still try to showcase the work of departmental faculty and staff, especially those who haven't presented recently, so that people are introduced and reintroduced to the wide variety of expertise in our department. And then we also have the goal of thinking about the Bay Area as a place where we can really try to facilitate connections and collaboration between our department and other people working in the Bay Area. So those goals remain prominent. And so when we select the speakers, these are always in the background. But in terms of the topics and where we want to push and stretch, these are our specific aims. So I want us to not only present clinical research and advocacy activity, but I want us to really think about how do we view it through the lens of social and environmental justice. And in particular, this talk is going to be talking about the lens of racial justice and equity. I want us to just be thinking about that in the background. And I would make the argument that these issues apply to almost any topic that we choose. I understand that they may not be the most important issue on any given topic, but I would argue that they're going to be important as we exist as part of a larger healthcare system. And for those of you who helped us find speakers, thank you. This was what we asked of you. We asked you to identify 1 to 3 people who you thought would support the mission and aims that I just told you. And then we reminded you that what we're not trying to do here is saying that we want experts, of course, in this area, but we're not saying you have to be an expert in this area. We're just asking you to challenge yourself to speak about how your work is impacted by societal structures and societal legacies. That's the challenge that we want for our speakers. And so I thought I would, if I'm going to put this down, I should tell you a little bit about how I've challenged myself in my work relative to this topic. Again, I'm not saying because I'm a wonderful person. I'm saying because I've been embedded in this system and been exposed to the harm it can do to patients. And so my world, I hinted at this before, my world is this weird world of who really has schizophrenia. And I've hinted at this before. I'm not happy that this question is asked of me, but it's one of the most common questions asked of me. And actually, 10 years ago, when I was even relatively new to the field, I actually wrote an article with Barbara Stewart, Kate Hardy, and Rachel Lowy, challenging this idea that this was what we kept getting asked. And so I really wanted to speak this notion. I really think it's problematic that we give psychosis this special mandate that if you're psychotic or not is the main question, that completely ignores the complexity of human experience, right? That somehow if I say you have real psychosis, I'm actually saying you're operating on some level of brain function that is different than normal people, and that ergo you have a biological problem, and ergo only medication will treat it. It's a very problematic logic chain. That's faulty logic that I just told you. And so there was this, I noticed right away that psychosis, even more so than mental illness, so I think it captures the same problem that mental illness does as a category, is it's framed as this all or none state. And it really pushes the clinician to do this perpetual search for what is real psychosis, and meaning real psychosis, meaning psychosis for which I don't have a good explanation, right? That's essentially what it means. And I want us to just pause and take a second what that means. What that means is psychosis for which literally I do not have a good explanation. So why do I get to choose what a good explanation for psychosis is, right? Which stressors really count? Which drug use really counts? As opposed to which psychosis is really inside your brain. And if I'm trying to justify which psychosis is really due to dopamine dysfunction, again, where we're gonna make some statement that sort of gets ahead of the science as a justification for why somebody has real psychosis. And this is a concept, this actually goes way back to Jaspers and some early theoreticians around this concept of psychosis. It cuts across, and I want to bring it up now, it's this concept of ununderstandability as being diagnostically useful. So we use it in psychosis all the time, or at least the system does. I try not to. The idea that if somebody says something that I can't empathize with, then that has clinical or prognostic value, and that person is more likely to have a problem with their brain as opposed to a problem of circumstance. Now, I understand at the extreme level, if you couldn't speak language at all, and that's the reason I couldn't understand you, I guess I would say that that's a big problem that partly exists inside of you. But I want us to think about how this plays out at the larger societal level as a countertransference phenomenon. And I like this quote. This is from Kamens again. I don't think it's malicious. I don't think we are trying to understand people. And I work with a lot of people who are, I would say, are hard for me to understand. And so I don't think I'm maliciously trying to label people as ununderstandable. But I feel like as a countertransference phenomenon, this all too human response actually kind of recreates the othering that the person is probably already feeling, but I just put a techno-clinical sort of jargon on top of it, right? So I translate my difficulty understanding you into real psychosis and a dysfunction in your biological processing that needs to be corrected. And I worry that actually works against reparative possibilities and actually reinforces stigma. So this is my worry, is that I'm just giving a techno-clinical explanation when I'm just turning ununderstandability into psychosis. So I want us to think about why people might turn ununderstandability into an othering. And so I want to think about sort of what are typical biases that all humans suffer from, and that at the societal level could actually be reinforced with a few sort of basic principles, especially DSM's assumptions about causality. So just to remind us, the concept of stigma is a complicated one. The dictionary definition is rather simple. It's a mark of disgrace associated with a particular circumstance, quality, or person. But I like this visual representation of stigma because it sort of points out sort of what sort of the different sort of outcomes of stigma are, of this mark of disgrace. And then it also just reminds us that, right, stigma inevitably exists in a power structure. And stigmatization inevitably gets used at the social level and the power level and authority. And so you can't separate stigma. It would be nice if we could. I think maybe we hope to do this. You can't really separate stigma or self-stigma or internalized stigma from the societal structure around it that reinforces this sort of what is a true mark of disgrace and what isn't. And so I was curious about this, and thanks to Barbara Stewart for helping me. I was a novice to this literature, but this has actually been studied. So these kind of, if you wanted to think about the historical change, DSM in 1980 does shift our explanatory models largely from psychoanalytic to what you might call biogenetic, and sort of an assumed explanatory model. And so I think the hope was, and if you read, NAMI websites and stuff, I think they still frame it this way. The hope was that if you framed behavioral disturbance as not a personality defect, but you frame behavioral disturbance as a brain problem, maybe that would actually take away some of the blame. Maybe that would take away some of the blame or the mark of disgrace for people. And so this is actually because this model, this biogenetics model of reducing stigma has been around for a while. There's actually been enough studies that people have started to review this literature. We have thousands of patients. This one's actually specifically looking at people diagnosed with mental illness as well as mental health professionals. So this one I think cuts closer to home than this general public perceptions. We're also thinking about mental health professionals. And what this article sort of argues pretty strongly is that the weight of the data suggests a couple of things that I think it's not that they're ridiculous, but I find them curious and problematic. So one of the things, this is not surprising. I often talk, when I talk with the trainees, I talk about how antipsychotics are way overprescribed. I'd say way overprescribed. And then they say, well, don't you think medication could be helpful? And I say, well, that's not the question, right? The question is not, of course, medication can be helpful. But if you believe that certain people can only be helped by medication, then you're inevitably going to overprescribe it. If you feel like that's the only, if somebody has a biogenetic problem, then the only tool you have is a biological tool. This is a logical fallacy, by the way. If you believe that, then you're only going to over-medicate. And this article suggests that this is part of what happens, is that people who more likely believe that behavioral disturbance, depression, or schizophrenia is due to a biogenetic in your brain problem will actually be much more likely to believe that medication will be effective. They're also interestingly likely to think that psychotherapy will be less effective. I go after this one in the schizophrenia world. People will say psychotherapy doesn't work for schizophrenia. That is not a true statement. So schizophrenia is difficult to treat, but I find it problematic that we've just decided that you're an other enough that I can't empathize with you, and trying to find some kind of co-constructed narrative is going to be useless. But this is one of the problems, I think, with the biogenetic causal model, is that it leads you into these sort of ideas that it's almost, if you think about it, this is kind of childlike logic, right? Biological problem means biological treatment, right? This is a problem, but it really plays out in the larger field, in my experience. And then there was a fair amount of data. This is opinion data, but it did seem like the biogenetic model, if you compared it to other models of schizophrenia, it tend to lead to more of an assumption that people wouldn't get better. So again, this is a problem in your brain. We don't know how to fix brains yet. We can't do anything. A fair amount more of fear or hesitation, and then a decrease in empathy. I'm going to come back to that because I think decrease in empathy is a real problem in our field. If we decide, I think that's one of the unintended consequences of the sort of biological model is that it decreases empathy. And so they make the argument that actually endorsement of biogenetic cause at the social level probably actually won't decrease stigma, but it will actually increase perceived dangerousness and pessimism regarding recovery. So this, I wanted to give this example because I think it sort of gets at the heart of our well-meaning assumption that if we reframe psychiatric disturbance as brain diseases, then we're actually reducing stigma. The data would suggest we're not. We're just reinforcing societal biases of dangerousness and hopelessness. But I want us to focus on decrease in empathy because I'm going to talk about the attribution bias, and I think these two things are linked, the attribution bias and a decrease in empathy. And I think there's a slippery slope when you decide that somebody is ununderstandable. So I want us to be careful about that. And that slippery slope is that a very common bias that we all slip into. We know we do it, but we still do it. We don't want to do it, but we still do it. And that is that people exist as person types, right? And that so there's a long history of this. Physiognomy would be one of the earlier examples of this, right? But I think we still do this, right? We still judge a person by their facial characteristics. We still do this. What I realized now, I can't watch a Disney movie now without being reminded of this, right? Disney movies do this all the time, right? The bad guy has the facial features of the person on the right. The good guy has the facial features of the person on the left. And you can see how this type of assumption that character can be driven by superficial characteristics really plays into racism and other types of bias at the societal level. And so when I walk people through it, I try to normalize. This is a normal bias. I think the problem is that clinicians have a societal power to reinforce this bias that non-clinicians don't. But we all go back and forth between explaining behavior from internal factors or external factors. We do this in our own lives all the time. We do this, people we care about, when they do something that annoys us, we come up with an explanation for why they did it. But one typical bias is that we tend to attribute good things in ourselves to traits, right? So I did well on that test because I'm smart. And we tend to attribute bad things or problems in ourselves to the environment, right? So, I hadn't gotten enough sleep that night. That's why I did bad on the test, et cetera. Whereas we're less likely to say I did good on the test because I got 8 hours of sleep, right? We're unlikely to make that attribution. And so, these are very typical. So we're attributing an internal or an external factor. So we're either attributing a disposition, that's the internal factor, or a situation. And we tend to attribute dispositions to others. That's what we tend to do. And we tend to attribute situations to ourselves. And it's probably because it's easier to do so. It's easier to do that. And it's probably because we don't have a lot of access to the motives of other people. And so we have a lot of access to our learning history and what we were thinking at the time and how bad we often sleep, things like that. We don't have access to that for other people. So it actually, in the absence of empathy, which is work, right? There's a lot of work in empathy. It's an easier explanation to assume that somebody did that because they're the type of person that does that. So this is a very common bias. We're all vulnerable to it. But again, I'm going to remind us, right? Empathy is one of the features here that I want us to be cautious of. And I think one of the problems with our biogenetic explanations is that they actually inadvertently lead to less empathy, not more empathy. So they're going to reinforce this dispositional attribution bias. And I want to give you an example of a study that stood out to me that still worries me and that I want to think about a little bit. This is just one study, so I want to be cautious saying that this is sort of an effect that cuts across large swaths of the psychiatric population. But most people, I think, are familiar with the implicit association test. And so what this study was doing was it was just saying, well, let's think about implicit association in psychiatry, right? Let's think about, what are just the associations that you learn from a basic learning theory standpoint? What are the associations that you learn in psychiatry? And so I'm going to show you some data that I find concerning, but I want to frame it first. And I want to just remind us of what we tend to do at the social level. What we tend to do with the attribution bias is we tend to layer personal judgments, right? So from our own learning history. So this person is the type of person, I've run into this type of person before, I know this type of person, right? And then, of course, we're in a world where we also then layer social judgments on these. And so what we tend to do in psychiatry, and you'll see this in psychiatry. Sorry, whenever it's not your fault. I appreciate the chat messages, but when I look at them, I have to reset my slide. So I apologize for the pause. And then what we do is we create these kind of meta categories. And I want to sort of give us some permission to sort of be okay with the fact that this happens, because this is not a terrible way to learn. It's just a biased way to learn. Right. So because human beings need categories to make sense of the world, learning categories is still helpful. Like, it's still helpful for me to have some gist of the psychotic patient. But that gist is my individual gist with a layer of the local society and a large layer of the larger society. And so I have to be careful with my meta category of psychotic patient that each step in this layer actually has some problematic biases in it. And I'm specifically choosing psychotic and non-compliant because I think these are common ways that we tend to divide psychiatric patients, right? So there's the patients who are neurotic or psychotic, right? Or they're psychotic or they have other quote unquote different problems or normal problems. Or this is the patient who has insight and does what I say. And this is the person who lacks insight and doesn't do what I say. And so I'm just for folks, I think most people understand what implicit association is at the basic level, but I just want to remind us what this implicit association test is, just because I was reading this data before I actually knew what the test was. So just a reminder, I'm just showing you the Stroop test first. The power of the Stroop test is basically demonstrating that human beings tend to turn things into categories when they're associated together, right? When they tend to go together. So it's much more congruent for us to see the color green and read the color green and read the word green at the same time than it is for us to say that the color is blue while we read the color green. And that's because the way that we learn them, especially think about when you were a little kid and you learn colors, the way that we learn them was at the same time. So we learn them almost as the same concept, right? They're just different aspects of the same concept. And so it's actually, this is a common way that learning works. Now I'm giving you the Stroop test because the Stroop test doesn't have much of a judgment layer on it or an emotional layer. But we also impose emotional layers on things. So I'm giving you an example of this is one of the implicit association tests that you can take at the website that offers these. And so we often we don't just identify physical differences between people, like how wide you are, how tall you are. We also put social judgments on them, and we learn those judgments together, right? We learn them as a society. And so what the implicit association test is looking for what are judgments and person types that we've learned together, and what are judgment and person types that we've learned are less powerful or less likely to be together. And so it's more difficult for us to attribute them. So it's kind of like the society's attribution bias that it's put on this sort of social judgment layer and this meta category. It's not just that you are thin, it's that you've worked hard to be thin, or that you exercise, right? There's these layers that go on top of it. And so what this study showed is if you just do a very simple version of this, where you just say, well, let's think of Black patients and white patients, and let's think of these simple meta categories that we apply in psychiatry. So psychosis or mood, that's probably one of the, in my experience, that's one of the primary first things people do in an interview is they try to say, is this a mood problem or is this a psychosis problem? And then compliant or non-compliant. And then do you need an antipsychotic or do you need an antidepressant, which are maybe the clinical instantiations of are you psychotic or do you have a mood problem? And what this is showing, look at the right shift here. What this is showing is that the congruence level, which is probably capturing the learning history. These are clinicians, and I'm going to walk through the data on which clinicians. This congruence is much higher for Black and psychosis, for Black and non-compliant, and for Black and antipsychotic. So to me, what this means is there's an implicit association that is probably learned in the healthcare system that attributes Blackness and psychosis as a similar phenomenon, and so forth, right? And this is an effect that I'm going to show you was extra worrisome when I found out this aspect of it. So I'm going to go to the next slide. So I've highlighted this for you. So they did, the participants were trainees or psychiatrists. And I just want you to pay attention to the lower left here. What it's showing here is that implicit association, or say that bias of assuming that Black and psychosis go together and white and mood go together more so than statistically chance. That bias actually gets worse through psychiatry training. So that one really stood out to me and really made me question my own well-meaning assumptions about how I approach patients from a culturally humble lens, right? And it made me say, well, what if the system I'm in, even if I try to do that, and let's say I'm even pretty good at it, let's give me some credit. I'm pretty good at self-reflection, and I go to trainings. Even if I'm pretty good at it, maybe what the system is giving me implicit is still a larger effect. Maybe that's still a larger effect. And it's actually affecting how I diagnose and treat patients in a large way, not in a small way. And so I want us to just think a little bit more in the last 10 minutes or so about how this history, this long history of assuming that race is a proxy for ancestry and biogenetics actually leads to real substantial changes in healthcare delivery and probable harm. So because I am not an expert in this, I did want to give people this resource. And in particular, it was outside of the scope of this talk for me to summarize such a well done and well-researched talk, but I think this webinar that I have down here, I would recommend that people see. So it really dives deep into some of the concepts I'm talking about. And the examples at UCSF that we've seen, I've been parts of. UCSF has done a good job of sort of trying to make this, really visible and have us as a field struggle with it. Even things that you wouldn't think of where racism would play a role. This idea that I'm going to call it society. It's race as ancestry, right? This idea that if the simple superficial difference is you are identified as Black, either self-identified or identified by somebody who decides you look Black. That very simple difference is actually such a good proxy for genetics and biology that you should compensate kidney function by a factor of about 20 to 25%, right? So think about the effect size that we're claiming is due to a genetic difference. Right? So these have huge potential outcomes when we assume that race is a proxy for biology. I'm not saying there was no data to suggest that people looked at this, but just think about the assumption that is due to a genetic difference that is captured by a superficial trait like skin color, I think is very problematic. And yet we kind of, in our day-to-day lives in medicine, certainly when I was a trainee, I would have read this without even thinking twice. I would have just thought, oh, well, good, I'm doing a good thing. I'm actually not being racist because I'm adapting my care to the different races. And then similarly, this is a factor, I chose this one because it's a factor of 2, right? That somehow just not being white, think about this, not being white, what is captured by not being white is actually that the biology of not being white explains 50% of an osteoporosis scale, right? So just think about what we're saying here when we use race as a proxy for biology. So this is the kind of thing that our field really needs to struggle with, right? Is how often are we doing this in our day-to-day experience, and how often do our systems of care reinforce this idea in ways that cause harm to patients? And I'm just gonna summarize some concepts. I know we're winding down on time here, but I do think that this talk is worth seeing. So if you have a chance, please take a look at it. But I just wanted to summarize. So I think this is the UCSF stance, and so I want to make it the stance of our department as well, right? So the way that we currently use race is not only outdated, but harmful, right? So it's not just that it's outdated and, oh, we're smarter now. It's causing actual harm. And just a reminder, because we always make this assumption, race is not ancestry. So the argument that evolution leads to genetic differences between populations is sort of true, like in some founder effect populations that are very small. But allelic variance is a very small effect, and it is not tracked with the superficial cultural construct that we use of race, right? Our construct of race is based upon some decided amalgamation of superficial traits. And I agree with this, and I want us to think about this in this Grand Round series. I want us to continue to reject the idea that race is a biological component of illness, and also that somehow we're being objective or unbiased when we say this. I think this is a common refrain. This is why I wanted to check our own reactions, right? A common refrain is, well, don't you think biology has something to do with race? Well, maybe something to do, but an extremely tiny thing to do with, right? The much larger effect is the social construct effect of race. And yet we're taught that somehow the biology is the unbiased or objective approach. I think that's problematic and just serves to reinforce power. I'm going to just end with a couple of examples in psychiatry, because these are very well replicated, but I wanted, because the implicit association data that I showed you really made me think about this. So I think we're more used to thinking about the kind of older 1960s kind of racism where, we identified, Haldol as something that could control violence. Remember this idea that biogenetic explanations lead to a risk of dangerousness, and that there was a violent type of patient. But for whatever reason, Haldol is still much more likely to be prescribed for Black patients than white patients. Just an odd finding, but that has held up over the past 50 years. And then if you do standardized interviews, what you find is that, non-standardized. If you non-standardized interviews, what you find is that very consistently, there's meta-analyses on this. Black patients are diagnosed with schizophrenia at least twice the rate, sometimes 3 or 4 times the rate of white patients with similar presentations. And there's evidence that that bias goes away if you make people do a structured interview. So it has nothing to do with the symptoms that people are reporting. It has to do with the interpretation of the symptoms that people are reporting, remember, as real psychosis or not. So think about the layering of that attribution bias and the larger social bias that DSM supports, right? This to me suggests that we're using primary psychosis as a proxy for otherness and as a proxy for a problem inside of you. And we're applying, probably implicitly, we're applying this idea that certain races are more likely to have problems inside of them. And then this one I still bothers me. I think it's related to the psychosis and psychotherapy idea, but there's pretty good data too that if you just do cold calling experience, patients who callers who identify as Black are 3 times less likely to get a call back from a therapist than callers who identify as white, controlling for the same insurance status. And so there's just another example of how, right, these kinds of what we think of as maybe small effects actually play out in large ways when they're amplified through society. And I would argue this may be related to less of a primary empathy or more of a feeling of otherness, or just maybe an implicit idea that some people will respond better to psychotherapy than others. So I just wanted to come back to our stigma diagram here and just think about the way that a racist system teaches us meta-categories is going to reinforce our all too human individual attribution bias, and I would argue limit empathy. And by limiting empathy, we're more likely to use a label as a proxy for a biological problem inside of somebody else. And in that way, we're actually going to reinforce exclusion and stereotyping. And DSM is going to codify the power that allows us to do that has very real consequences for our patients. So these are some summary points. I'll let you read them. These are just some ideas to approach the seminar series moving forward. And this is just a final pitch. I think this may be a topic for grad rounds later, but there are some approaches that try to address these types of systemic biases. This is one example. So I'll leave it for folks to explore on their own. It explicitly tries to address some of those problems of power, privilege, and bias that I talked about. And I'll just end with this sort of problem as being something that we want to try to address in this series. Thank you for your time. I think just a reminder is I can make the slides available. So yes, the answer to that is yes. So I think we have by my clock something like 7 or 8 minutes. So I'm happy to either take questions in the chat or comments. And then also if you raise your hand, I think Gina can turn on your microphone if you have a question that's easier or a comment that's easier to state verbally than type. I appreciate the consequence, right, that I'm talking about the racist history, but certainly capitalist principles play out in medicine as well, right? So there's intersectionality between some of the different systematic aspects. I still find it problematic that I'm rewarded for seeing more patients, not for my patients getting better, but that's a little bit of a side comment. So I see a hand raised in the camera. That's Anne. Sorry, I can only see a few people. So if there are other people with their hands raised, Anne, please.
First of all, hi, Damian. It's nice to meet you, and thank you. Um, yes, I was raising my hand instead of doing it digitally initially. So this is such an important topic, and I'm not asking you a question that I imagine you have a clear, settled answer to, but I want to hear your thoughts. How do we go from describing this phenomenology and becoming more aware and conscious of it to actually changing our practices on a daily basis? So obviously you've mentioned reflection, and I made a comment in the chat that I think, you know, there's a lot about medicine also that reinforces our biases, because what are we doing but learning patterns for many years of our education, you know, like, and we know, we have studies that document that the difference between experienced seasoned practitioners and new ones are actually pattern recognition.
And it's often a good thing, right? It's often
There's a right, like,
yeah.
like you see a patient, so in a sense, you see a patient come in, you know exactly what they have, and this can even happen in a mental health specialty, which is amazing. But it's also this double-edged sword, because it reinforces every single bias we have. And we know that physicians, besides that, have enormous biases related to their practice. So how do we dismantle that, Damian, both in our educational programs, but also for people who are not in educational programs anymore?
Yeah, so I mean, this is where, so I'm going to go after DSM, and I think people who know me kind of maybe think I'm this kind of ranter and I'm just upset with that it's not perfect. Actually, my problems with DSM has nothing to do with it's imperfect. My problems with it is that it is one of the largest effects that, especially when combined with the capitalist healthcare system, right? It is one of the largest reasons that these biases play out as harmful. And so I can't change DSM by myself, but I feel like what I would say, I talked a little bit about this last time when I talked about more about DSM, is I think, because this is what I do when I work with trainees and I try to do this in my practice. Nobody is allowed to say that the problem is the diagnosis. You have to tell me what the actual problems are in behavioral measurements that you can share with the patient. So I'm not allowed to say to you, I'm treating your schizophrenia. I think that actually, again, this is where you have to check our defensive biases. That doesn't sound like a bad thing. I'm treating your schizophrenia. It doesn't sound like a bad thing to say. But I think it actually reinforces the idea that you have schizophrenia, my treatments are biologically addressing your biological deficit, and that certain other treatments may be less effective, and that reinforces that biogenetic stigma. So that would be one of the things that I would say that we could do in training, is that we would, instead of saying we're treating a diagnosis, we would actually say what we're treating in the chart, and it would be documented in the chart as a problem list and not a diagnosis. Although my fear, Anne, is that we've actually moved in the opposite direction in the last 5 years in terms of documentation. I appreciate the question about sort of what would you do, what could the individual practitioner do to address these biases? I mean, I don't, it's a good question. I don't see that as a bad thing to try. This is Emma's comment. I don't see that as a bad thing to try. At least you're trying to explicitly do that. I mean, probably, I mean, I would draw on some of the literature from things like, you know, like orchestra auditions and things like that, right? Right. Try to decide ahead of time what your criteria are for patients in a very proactive and methodical way, and then whoever calls, just see if they meet those criteria, and be very, very clear that if they meet them, you see them, and if they don't meet them, you don't see them. And then you know, you probably can't get away from your own eyes and ears, but that would be a way to reduce that type of bias, which probably happens quickly and unconsciously. All right, I think we're at time. as always, I'm happy to stick around for a few more minutes, but I realize people have places to be. Welcome to the Grand Round series. I look forward to sharing more talks with all of you again, and take care. Happy Tuesday.